Hello and welcome. I'm Dr. Dalton Norwood, scientist in the Division of Preventive Medicine in the University of Alabama at Birmingham, and I'm joined by Dr. Ramzi Mulki, advanced endoscopist and assistant professor here in the Division of Gastroenterology. We are pleased to guide you through our study entitled The Effects of Glucagon-like Peptide 1 Receptor Agonists, or GLP-1RAs, on gastric retain contents and mucosal visibility scores during EGD. Dr. Mulki?
Thank you, Dalton. And on behalf of the co-authors, we'd like to thank the GIE editorial team and reviewers for taking the time to review our article and the opportunity to present our findings in GIE.
Thank you, Dr. Mulki. It's a pleasure to have you here and working with you on this study. We know that GLP-1 use has become widespread and it's increasing. Tell us why this is important and what motivated you to embark in this study.
Thank you, Dalton. Well, as you're aware, the obesity epidemic continues to increase. I think we're going to continue to see more patients on GLP-1 receptor agonists, especially after some have been FDA approved for the management of obesity. And this is going to have some implications in the perioperative period.
Okay, what are these potential implications in the perioperative period?
Well, as you're aware, Dalton, some of the mechanism of action of GLP-1 receptor agonists include delayed gastric emptying. And so there's a concern that the delayed gastric emptying may result in retained contents, which may put patients at risk for aspiration, especially during upper endoscopies. Dalton, so why don't you guide us through the methodology of our study?
Of course. So we perform a matched pair case control study in our institution. We match individuals by age, gender, and diabetes status. We pull data from our institutional database, searching for patients on GLP-1RAs that had an endoscopy performed in the time period. We excluded individuals that had a concurrent colonoscopy or gastric altering surgery, as well as individuals with missing data. Our primary outcome was assessing the mucosal visibility score, which is done by a validated score called the POL-PREP score that ranges from 3 to 0. And this was assessed by a single blinded gastroenterologist. And our secondary outcomes was the finding of gastric retain contents and aborted procedures and rate of adverse events such as aspirations. So,
Excellent, Dalton. I think one of the unique aspects is that we use the validated score. So, Dalton, why don't you run us through some of the results?
of course, so after exclusion and propensity score matching, we found that we ended up with 84 pairs of patients. The median age was 55 years old. 71% of them were females, and 60% were from white race. There were no differences on the SAA status, in the diagnosis of gastroparesis, the use of promotility agents, or opiate uses. The most common medications that we found were dulaglutide and semaglutide, and patients on GLP-1 medications were on the medication for about 331 days in median, almost a year. There were no differences in the timing since the last fluid intake or the last solid intake for both groups. Most patients were sedated using propofol, monitor anesthesia care. Dr. Mulki, can you go through some of the main findings?
Excellent. Yes, thank you, Dalton. So when we used the qualitative score, we found that patients were more likely to have retained gastric contents if they were on the GLP-1s. In addition, they were around actually 4.6 fold. In addition, when we looked into the validated POL-PREP score, the mean score was much lower in the GLP-1 group compared to the non-GLP-1 group. And then the odds of having a score of 0 compared to 3 was 2.4 times more likely in the GLP-1 group. And so overall, the data points to retained gastric contents and poor visibility because of the retained gastric contents. And we actually had 4 patients that the procedure was aborted, and that was all related to retained gastric contents.
Okay, perfect. Yeah. And this was in what group? In the GLP-1 group?
Yes, it
Okay,
was in the
perfect.
GLP-1 group.
So wonderful. So in summary, we can say that GLP-1 use is associated with lower mucosal visibility scores, with more gastric retain contents, with more aborted procedures, and with there was no increase in adverse events such as aspiration, right?
That's correct. There was
So
no difference. So despite the increase in retained gastric contents, this did not translate to adverse events.
perfect. So Dr. Mulki, in your opinion, what do our findings add to the existing body of literature, and what are the strengths of this study?
Well, our study continues to add important data to the current body of literature. And I think that the fact that we used a validated score is one of the strengths of our study. And the fact that we did a meticulous collection of the data, I think is another important strength. We did have the limitations. Do you want to highlight some of them?
Of course. So first of all, the retrospective nature of our study has inherent limitations. Additionally, our sample size and the fact that it's a single center study limits our ability to generalize these results. Um, Dr. Mulki, with the insights we have gained, what do you think are the next steps we should take in this line of research?
Yeah, I think we need more prospective data that looks into a larger number of patients in a variety of clinical settings and different types of GLP-1 receptor agonists, and to assess clinically important outcomes such as adverse events, aborted procedures, repeated procedures, and the cost associated with it. And I think we also need trials to investigate some of the things that we can do to mitigate some of the effects of GLP-1 use in the perioperative period.
Definitely, very, very thrilled to see this research coming through. And well said, Dr. Mulki. Any final thoughts as we wrap up?
Yeah, so as GLP-1 receptor agonist use continues to increase, I think we're going to see obviously more patients presenting to endoscopy on them. And I think it's very important for us to be aware of some of its effects, both the endoscopist and anesthesia provider. And we look forward to seeing what the data will show in the future.
Perfect. Thank you, Dr. Mulki.
Thank you, Dalton.